Thank you so much for attending this talk today. This is a new way of looking at burnout in community and residential settings. My name is Max Zubatsky. I'm an associate professor in family community medicine here at St. Louis University. I also direct the Family Center for Healthy Aging, as well as the co-I on our HRSA Geriatric Workforce Enhancement Program. So this talk is really going to address beyond a new way of looking at burnout in healthcare settings and specific to those who work with aging patients, residents, and family members, just knowing how big of a topic that this is in our society. Just a disclosure statement that this work is part of a larger project under our HRSA grant for this coming year, and some of the information and areas that we do disseminate from this topic as well. So I was thinking about some alternate titles for this talk, and just thinking about how we all go through some form of burnout or fatigue as professionals. So thinking about where to turn to when you feel burned out, looking for answers, finding areas of resilience to address. Wait, what exactly is resilience? Of course, we're all burned out. So can I now get back to my 6 projects for work now? As we speak, I'm currently multitasking my scheduled emails and texts while watching a talk here on burnout. So it's all playfully to say that we have a lot of impacts and stressors and tasks that we have in our work and our job, but it's important certainly to take hold of working together as a system and as a team in healthcare. And we'll get to why that's so important and some evolving terms around this. So just around the state of burnout in general for healthcare professionals, it's the big buzzword. It has been for many years. Obviously, the increase of burnout across professionals is correlated with higher caseloads, additional requirements from insurance and third-party payers, the number of patients, number of referrals, and the high turnover in staff of professionals in many of the settings. Obviously, the pandemic has exacerbated much of the burnout that we are seeing in many of these settings. So administration and management are really key as far as addressing this in staff and employees. I got to see a lot of the scope of burnout with medical students and residents, and this was long before COVID. And when we talk about this, how do we protect younger generations of medical professionals, of allied health and behavioral health professionals alike? But hopefully, this talk can normalize that some stress and lower levels of burnout can still be tolerated, and how we work through it. It's when it hits a bigger point, but also really out of our grasp, that it starts to be really problematic, not only in our personal lives, but in our patient work there too. So just a difference in what we see for burnout and compassion fatigue. Both of these like to be used interchangeably, but they have some pretty stark differences where burnout relates to an individual coping and stress factors in one's personal and professional life. So again, this is a little bit more professional based. There's some internal challenges that happen that can lead to more personal struggles even outside of the workplace. Where compassion fatigue, the direct care that you have for a client, a patient, a family, is a relational problem. It's relational in nature, where there's something about that dynamic that really forces us to feel a sense of being burned out and really depersonalizing our sense of compassion for the patient and care that we're working with. And so we do see this a lot of times in nursing homes, long-term care facilities, but also in outpatient, secondary, and tertiary care settings when, again, we have to manage very high caseloads, working with complex comorbidities for older adults. This comes up quite a bit. Two specific areas that we see burnout happen a lot. One is with intellectual and developmental disabilities. There's a lot of the role ambiguity for staff and providers taking on multiple roles, based on who they're trying to treat at one time. There's the perceived overload of the amount that you're trying to care for this population. This population certainly not only may have some physical challenges, but when there's cognitive and communication speech challenges as well too, it forces more of a team effort, but staff trying to be on an island to address this can be very, very challenging. We also obviously want to always have person-centered care on the forefront when we're working with this population. But we've seen where this framework and culture is associated with better job satisfaction and well-being for professionals. So that's something that we're starting to see in the research a lot more too. We're also seeing obviously burnout take place in nursing homes and residential facilities following patient deaths. And this is really difficult, based on those that are going through a tough time handling other patients and caseloads. How do you process this with team members? How do you get support? How do you have to find resilience as a provider? And there's been many who have reported in the research that there's an avoidance of grief, almost a conflict avoidance, not only bringing this up to administration or directors, but also a depersonalization in their own work and a sense of learned helplessness. I have to move on. I have to get over my grief over working with someone for over a decade, and now they're no longer in my life professionally. A study from 2022 said that almost 90% of nursing homes reported moderate to high levels of staff shortages, largely due to post-pandemic burnout and poor supports from administration. So you can see this is a very troubling trend that's happened even post-pandemic. I always give the analogy that in 2020 and 2021, we were almost, rowing in the ocean without paddles. And so we had to stabilize it in a lot of these settings until we could really get good footing. Well, the problem is when we're kind of lost at sea and trying to find our way back here, there's not as many people in the workforce. We're also experiencing a huge shortage of geriatricians and those seeking geriatric positions in our healthcare settings. And so it's not only addressing those that are trying to manage things now, but who's going to come in the forefront in the years to come and even decades to come to address a growing need for the older adult population. Many of you have heard around the Maslow Burnout Inventory. This is the shortened version for health services professionals. So you can see that if we were to give this inventory for someone, they would check this off, treating patients as impersonal objects, feeling emotionally drained. It's really a strain. I don't care what happens. Certainly these would be risk factors, but this is also individualized to the person. It really doesn't talk about the underlying motives or factors that are happening in the system at large. So if someone fills out this inventory, you would say they probably meet a good threshold of being burned out. The problem is not only what do we do with that, because I think we're still lacking really concrete follow-up interventions for burnout, but what's the bigger system change that's taking or not taking place around this? So, we see this as a binary construct. We're either burned out or not burned out. And I think this can be really detrimental to many settings in thinking about that because, when we create a dividing line, it's where do we meet in the middle? When someone is burned out, do they need extra counseling or mentoring or help or resources? Well, it could just be at a lower level and they can still manage a lot of their day-to-day and week-to-week tasks that they have working in these types of settings. So in 2020, a colleague and I had put a chapter in our book around a spectrum of burnout, specifically for behavioral health providers, but we do feel that it could apply to medical professionals and others that work with the aging population and especially in long-term care. So you can see at level 1 or 2 where there could be minimal stress, a lot of those day-to-day tasks, deadlines that we have to hit. As I'm giving this talk, it's right before the holiday season. We have a lot of emails and deadlines and things that are taking place. Some people who are working in more residential or community settings, there may be a little bit more depression or loneliness that you're trying to, work during the holidays. So this often comes about. It's really more when people reach level 4 and 5 in that moderate level, that we start to see some of the anger, frustration impact not only people's to patient care, but also in their personal lives as well too. And it's at that threshold that we really have to address this, but also knowing that if there's systemic problems that are out of the grasp, why is this happening? And who else is involved that needs to address this at a larger level? So we know of all these things that are happening around burnout, daily functioning, labeling the issue. We need support. We need to find help and address these internal struggles. But now what? So we've had this term burnout for so long with staff, providers, professionals, even caregivers who are both family, professional caregivers alike really struggle with this. So in the last decade, there's really been a new concept that has come to fruition called moral injury. And I think this is something that's really defining those that are working in larger systems and those in the community where many things are out of people's grasp. And so we have to look at larger structural changes that take place and really navigating how providers can really find the controllable, uncontrollable elements of their job, knowing that there's higher level administrative and systemic challenges that do exist. So the development of moral injury, this even came prior to the pandemic, but really took hold afterwards. We see that burnout is a problem, but we've almost used it as a individual pathology to kind of self-diagnose or self-define people's symptoms that's happening around work. When we're leaving out the larger pressures that are happening in the healthcare system, especially with the aging population. So a lot of topics that are coming up now are, the pressures for billing and coding and for reimbursement. Where are resources in the community? Where's the staff that can help, cover when I have to work a few hours overtime? When I'm not doing unpaid for overtime, how am I getting this acknowledged by administration when there's tasks needed in the EHR and no one's answering it, or I'm not getting additional help? I feel like I'm on an island. So a lot of professionals may not necessarily feel that they're disliking their positions. There's just a sense of feeling demoralized that the healthcare system, and especially in the aging health system, there's such a lack of resources and acknowledgement of things that are going on. So the best definition I could find from the King's College in London for moral injury refers to an intense psychological distress which follow actions or oftentimes a lack thereof that strongly clash with someone's moral or ethical code. We all have a moral and ethical compass as professionals, and obviously we all take oaths as we get into our different professional disciplines to do the best job possible to take care of the patient, the family, those that are in front of us. And when there's decisions that are outside the range of our path and our own ethics, it can create massive challenges and a lot of internal struggles that we deal with here. So moral injury can really be separated based on three different categories and types of situations. The first is acts of commission, and this is really the event that takes place. This is the most common as far as I mentioned before, a specific patient encounter, something that's not happening on that same day, the lack of coverage, the lack of acknowledgement, forced to have to do an event or something that goes through which is against what someone feels was necessary. This can even get in again to coding, to medication errors, to decisions on healthcare decisions that's largely out of the provider or staff's control. The acts of omission could also be an action that could be taken. A colleague takes an action that someone does not disagree with, but where do they feel they have the leverage to report this? Or even administration are making decisions based on the whole setting that are not conducive based on staff or provider shortages or healthcare decisions made for their patients and residents. The final one is betrayal. And this is seen oftentimes where the structure or administration higher up is making decisions and feeling like the providers and the on-the-ground people working with residents, patients, and families feel on an island. It's almost a separation of two worlds. You have the decision makers and you have the ones who take care of all the patient care and execute everything. And when they're not talking, they're not being transparent with each other, that's a lot of where that moral injury effects often happen. So there's starting to be some research that's seen on this, especially in, as I mentioned, nursing home and long-term care facilities. So when this is perpetuating, failing to be prevented over time, and people learn that their deep moral beliefs are being challenged or not honored, that's where problems really exist. And you can see on the bottom outcome, that perfect storm, when personal, professional, and systemic or structural factors all converge, that's what really leads to a lot of the frustration and negativity that you see in nursing home long-term care facilities. I think we've seen that really resilient teams have creative strategies, but also a culture of positivity, helping each other as a team and unit and not leaving each other on silos. So again, with the lingering effects from the pandemic, with financial and professional shortages, it can create what we call this morally injurious experience, where someone can be almost traumatized from an action or decision or even that betrayal type of moral injury, that it really affects the type of conditions that they're working in and the type of quality of care that they can provide. So obviously there are demands and health consequences, from COVID-19, and they've lessened, but the organizational burdens that come from it have still not subsided by a long shot. And so when you see a lot of the emotional and psychological risks that this puts on the frontline staff and providers, can create enormous long-term consequences. So I mentioned the continuum for burnout. What would a continuum of moral injury look like? Well, when we think about healthy functioning and day-to-day tasks, and you're not impacted by any of those three areas, there's no moral injury effect on the provider or staff member. But as you go across the continuum, when you see any of these warning signs or one or more of those injury causes take place, that's where we really have to address things. And I'll talk about where administrators and even professionals have to be transparent with each other and really just talk about effective solutions that take place. So I use a lot in my practice, my teaching, my supervision around what's called self of the therapist. This applies a lot to behavioral health professionals, but when we're even working in long-term care, senior care, nursing home facility environments, the self of the professional really comes to the forefront as well. So elements such as finding empathy and gratitude for the work that you're doing. It's that day-to-day experience. I'm making a positive contribution to the patient, to the place I'm working in, to the world at large. How are you attuning to your biases and beliefs that are going on? So this is not only towards any of the system-wide changes or things that people feel that they can change, but also, are you attending to cultural or ageism or socioeconomic status that's related to your patients? So not letting these structural areas impact biases and beliefs you have towards the patients themselves. Controllable versus uncontrollables, I think, are really important. I think where we've seen management of expectations in a lot of settings that we tour and we collaborate with, that's effectively knowing I can control only what I can, and the uncontrollable, I can't force it, and I can give feedback, but have to work within the grasp of what I can possibly do. But also knowing the final thing, be the change, be the outlier, be someone who's creating positivity. Like I said, it only takes in that continuing system one person to infiltrate the positivity across a lot of negativity, and that system has to change. So are you perpetuating the cycle of negativity? Or are you breaking it if there are challenges going on at your site? The same thing for administrators. I think there's a lot of the self aspects that have to be taken in, and not just around management decisions too, but what are you doing to support and try to alleviate a lot of the moral injury taking place? The reasonable expectations for employees. Again, where do their biases and beliefs come from on, workload and caseload expectations? The bottom part around transparency on any systemic changes. I think that's where really effective administrators in these types of settings say, hey, we can't detail everything, but here are some of the contributing factors to why there could be more stressors taking place, things that are affecting our patient care, our bottom line. Having those transparent conversations are really important. And then most importantly, creating a team-based and collaborative culture of care. I can't stress how important that is, where seeing higher levels of integration and collaborative practices make a huge impact, not only on the outcomes of patient care, but also how the viability and positivity of the team lasts for a long, long time. So looking at those two levels are really important. So obviously, having an exercise of self-acknowledgement of compassion is important. These are just some example statements you may want to keep thinking about, reminding yourself that you're making big impacts if you work in these environments or know people. So I still make a positive impact in my workplace by the one thing that I can't control in my workplace is this. Again, that's the uncontrollable. One important quality that my patients, residents, and colleagues might say about me is this: not assuming the negative, not thinking or mind reading that there's negativity or catastrophizing, but assuming that you're doing good work from others is really important too. So how do we address this if it does occur in the workplace? Well, I think, again, finding out the source of where it comes from is really important. And again, getting away from the pathologizing of individual burnout is really an important step one. That everyone's going to go through that lower level one or two stress, job demands, deadlines. It's within the nature of healthcare. But how you address it and how the team can really help is going to be uh, up to that setting as far as how they address it. Reframe the injury that it's something else other than a deficit in the employee or worker. A lot of competent staff providers and professionals and community workers do excellent job. So separating the quality of work from the stress that they go through and the needs to make sure that they're feeling supported. We have to see those distinguished from one another and not just combining into one. A sense of community and collaboration across the team is really important. And again, team bonding, team skills, especially working in these types of settings, is absolutely critical. As I mentioned before, when we're having a huge geriatric professional shortage in this country and even globally, it's going to be more important that we give precedence for acceptance of what people can handle within a given workday and a week, and not overloading as much as a result of shortened staff or resources that are taking place at a site. We have huge pressures on productivity. I'm not saying that's going to go away, but again, the culture is what can be controlled. And again, where administration directors or even the collective group of professionals have to make sure that that's in place. And that comes with communication across to all levels. And again, what can you control and not control in these settings is going to be really key. So I end with a few positive quotes that I think could be beneficial. Gratitude turns what we have into enough. I always give the just enough approach, or the better than good approach, to people that I supervise and to a lot of other colleagues. And that gratitude is not only the greatest of virtues, but the parent of all others. So how are we showing gratitude to our colleagues, to those that we manage, those that we work with? It's important. Again, the timing of my talk before the holiday season is not just a one-time occurrence at the end of the calendar year. How are you making that intentional, and how are you making a cultural change to make sure that your whole team thrives and that they know that throughout the year? So I thank you for hearing about this. Again, if you have more information, we have our new Family Center for Healthy Aging that you can reach out to us through our email. You can contact me with any questions. And this is a really important topic. I know that's going to apply to a lot of people across a lot of levels. So I hope what this does is give you more ideas and also more questions, because I think that's going to bring it back to your work setting for researchers and clinicians. You put this into practice and talk more about it, because it's really valuable. So I thank you so much for your time. Take care.